Our next talk, the next section will be about chronic functional constipation diagnostic tools, and the first speaker will be Professor Dr. Marwa Deeb. She will talk about nutritional perspective and microbiota.
السلام عليكم تاني. انا اول مره اعرف ان السيشن اسمها diagnostic tool، لان انا مستغربه ان انا هقول اول حاجه وانا هتكلم على nutrition perspective، بس it's okay، يعني تغيير عشان diagnostic tool غالبا هتبقى very dense. functional constipation. Now I'll talk about the nutritional perspective. treatment pillars زي ما دكتور شريف قال لنا in short في presentation هتفضل the same في chronic functional constipation. bowel retraining اللي هي أساسها طبعا إن أنا I need to explain the condition, why did it happen if I'm lucky enough to know the cause, and then the cornerstone is use of laxatives في disinfection period، وبعد كده في maintenance period، وبعدين حبة صغيرين في الآخر على role of diet. التوليت ديسنسيتايزيشن شبه قوي اللي الدكتور شريف عرضه لنا مع الانيوريسز او الباول اليورينري بروبلمز، يعني ومفيده ومهمه ولازم ارينفورس وافهم الام ازاي تعملها في كل مره. انا الفوكس on the non-pharmacological intervention اللي هو role of nutrition، وانا اسفه لو الجمله دي صدمه، but this is in all guidelines of management of chronic constipation in children that there is no special dietary modification that you need to push on the child. It's never a front line. يعني ما ينفعش تبقى خناقتي وانا قاعده in this very long session زي ما دكتور شريف قال. It's the first time encounter with a patient with chronic constipation هي 45 دقيقه، يعني العياده من اولها باظت غالبا. You don't need to waste time discussing extra dietary reinforcement. العيان ياكل usual diet بتاعه، بس take care of this point. The eat well plate ده معروف في كل الدنيا في الأطفال والصغيرين أو أطفال والكبار I mean. we think إن الولد بياكل كده، هو ما بياكلش كده. يعني أنت تقول له ياكل عادي، فالعادي بتاعه إنه هياكل بيكريز كتير، مش هيشرب مية، هيشرب عصاير طول الوقت، هيشرب ألبان طول الوقت كتير أكتر من recommended intake في eat well plate. okay I'm not reinforcing special dietary interventions، بس at least I need to make sure that he's eating well, he's eating right. وده البورشنز اكيد في الجراحين ما فيش اي حد هيحب to discuss this، لكن this is the eat well plate. effective dietary fibers. الفايبرز اكيد مهمه، واكيد we need to make sure that the child is eating good amount of fibers, but guess what, the needed amount of fibers اللي هي ليها equation كده غلسه شويه، بس the needed amount of fibers could be consumed لو اكل في اليوم تفاحيه، لو اكل في اليوم خيارتين، مش لازم ياكل خس كتير وجزر كتير وجرجير كتير، مش لازم. يعني the needed amount of fibers مش كتير قوي زي ما احنا متخيلين، it's only the usual. and take care when you advise extra fiber supplementation في الأطفال you need to make sure that he's drinking enough water، والا هنبقى عاملين قفله جوه مش لطيفه خالص. الفايبرز insoluble او soluble ليها different mechanism that it can encourage الcolonic motility، من اول increasing the stool bulk، fermentation اللي بيحصل في الكولون للsoluble fibers بيحسن الstool consistency، producing short chain fatty acids ودي هتكلم عليها بعد شويه، positive effect on gut microbiota. الجات بتاعتنا colonized by a very big number of different organisms مش بس بكتيريا. Fibers represent the lunch box. It's how you feed the bacteria. So when you feed the bacteria in the right way, it will improve the motility of the intestine. ده example soluble or insoluble fibers. بعلم الأم إزاي تقرأ nutrition labels which are definitely defective for us. And this is the recommended intake في كل الأطفال whether they're constipating or not. Age in years plus 5 to 10 grams. تفاحية. يعني لو بياكل تفاحية he's taking his enough amount of insoluble fibers. Daily fluid intake. This is the recommendation of the American dietary recommendations في الأطفال لل effective fluid أو sufficient fluid intake. والfluid intake مش المقصود بيه العصاير ومش مقصود بيه البيبسي ومش مقصود بيه الألبان. dietary fluid intake مقصود بيه المية و any clear fluid زي المية. أعشاب ينسون معرفش إيه whatever شوربة. Okay, these are the clear fluid recommendation. من الحاجات اللي احنا we tend to overlook مع ان احنا مجتمع حر. So we need to make sure that that child is drinking enough water. بالذات لو العيلة ما عندهاش الكونسبت ده مش هتشرب مية أصلا. أهو effective cow milk elimination. كل الجايد لاينز في الاطفال اسبيجن ناسبيجن this is the American guidelines NICE guideline Canadian guideline British guidelines غير النايس another British Society guidelines of gastroenterology كلها بتقول if you have a child who's refractory to the standard treatment of constipation so this is number one يعني انت مديله sufficient medical treatment which is proper and he's not responding well ما عندوش alarm symptoms and signs عنده family history of allergic diseases whether rhinitis, eczema, bronchial asthma, food allergy only then you're justified to try a limited trial of 4 weeks elimination of cow milk products. مش كل عيان معدي جنب الconstipation I have to suspect وحط عليه الليبل اللي دكتور شريف قال عليه ان هو allergy. This is a very 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 sad practice. I know it's over يعني it's مش عايزه اقول usual بس it's done في اماكن كتير ومختلفه بس بصراحه الجراحين in general they resist in the cow milk allergy could be a cause and it is a cause يعني the guideline says 4 weeks elimination trial if the patient is responding well you do not diagnose allergy if the patient is responding well to elimination you have to re-challenge يعني you have to try cow milk again and when the patient gets constipated again the very bad form of constipation the refractory one only then you're justified to put the label of cow milk allergy يعني مش عشان هو اتحسن على الألبان طب ما هو يمكن لما شلنا الألبان بقى يشرب مية أحسن ممكن لما شلنا الألبان بقى ياكل أفضل حضراتكم فاهمين قصدي يعني هو مش الغلط في الكونسبت هو الغلط في تطبيق الكونسبت ان كل حد constipating يلا وقف الألبان and guess what أغلب الأولاد اللي عندهم constipation they tend to consume large amounts of milk لان احنا عندنا كونسبت كلتشر كده بيس في دماغنا ان كل ما شربنا لبن كتير كل ما الباول موشنز بقت احسن ده لو انا عندي لاكتوز انتوليرنس لكن لو ما عنديش لاكتوز انتوليرنس انا كل ما هشرب لبن بكميات مرعبه I see kids consuming 1 liter plus of milk ده غير بقى الحاجات التانية غير الجبنه حتى اللابتوب متاثر من الموضوع غير الجبنه وغير الرايب وغير الزبادي وغير حاجات تانية كتير فيها البان يعني لو حضراتكم خدتوا بالكم من الهيستوري يعني the devil in the details زي ما دكتور شريف قال if you ask about the consumption of milk in most of children with constipation it's high because they think it's the easy diet ما بيحركش الباول movements جامد فما بيعملوش pain فبيقدر يكمل فيه with easy food يسمح له ان هو يلعب ويعمل حاجات كتير so these are the conditions You try elimination trial in children who are refractory associated allergic manifestations. يعني لو هو الولد نفسه عنده eczema, عنده bronchial asthma, I am justified to think of cow milk allergy as a cause. And constipation is the most frequent delayed manifestation of cow milk. Cow milk allergy is a diagnosis بيحصل أكتر في أول 3-4 سنين من عمر الطفل. When I see a big child 5 سنين 6 سنين ويجي لي في بالي انه ممكن يكون cow milk allergy انا مش بعيد عن ال practice يعني because it is a frequent delayed manifestation of cow milk allergy and this is a very interesting review 2022 مش في مصر معمول في tertiary center بيقول ان children referred with constipation 14% respond to dairy products elimination 4% respond to multiple food فما ينفعش يعني ابقى تفكير والمالتيبل فودز دي على فكره على راسها the wheat the eggs the soy وحاجات تانية غريبه مش هقدر اقولها دلوقتي عشان الناس بتبرق لي جامد بس يعني other food could be incriminated في الالرجيك colitis that predisposed to constipation في عيانين الكاو ميلك allergy ليه بيحصل لهم because there is eosinophilic infiltration it's an allergic process eosinophils وماست سيلز وحاجات كتير ماليه الريكتال ميكوزا عامله انفلاميشن وعامله ديسموتيليتي فاكن الكولون او الريكتم exactly holding الستول inside ومش عارف يخرجها a condition specifically termed as outlet dysmotility or rapid transit constipation يعني مش slow transit اللي هو الوحش الغلس ده لا they have rapid transit and then the stools are held in the rectum why because the rectum is inflamed but دايما بشرحها للأم إنه when you have an inflamed finger you cannot move it and the same happens in eosinophilic infiltration that happens in allergic diseases the rectum cannot move cannot يعني ايه give you the extra push that would expel the stool outside واحد تاني من وطبعا increased tone of anal sphincter حاجات تانية مش بنشوفها بعيننا لكن one of the very very strong theories that underlie constipation in children with cow milk allergy is the dysbiosis the alteration in the gut microbiota that is clear and identified and studied in children with constipation سواء مع الالرجي او لا الجت مايكروبيوتا اللي كنت بقول لحضراتكم عليها جزء كبير من دورها المهم في حياتنا حاجات كتير، بس جزء كبير في الكولون is the intestinal أو colonic motility. if the gut microbiota is disturbed لأي سبب بقى، باخد antibiotics، باخد أي أدوية، أي سبب underlying the gut dysbiosis مش مكانها أكيد دلوقتي will affect the intestinal motility. ليه؟ Because the gut microbiota has a direct effect on the intestinal neurons, on activity of the enteric nervous system, a direct effect on these. Good gut microbiota لو الميكروبيوتا بتاعتي كويسه it will release metabolites زي lipopolysaccharides, short chain fatty acid, butyrate, propionic acid, tryptophan metabolites. All these, and even bile acids, all these stimulate intestinal secretion and stimulate gut motility through acting على ال 5-HT receptors, وال 5-HT receptors بتحسن الintestinal motility. يعني okay, so this is how dysbiosis can have a role in the etiology of functional constipation. الميكروبيال signature أو بصمة البني آدم اللي عنده constipation قليلة فيها البكتيريا النافعة زي اللاكتوباسيلس والبيفيدوبكتيريوم، وزايدة فيها أكتر البروتيوليتيك بكتيريا سواء enterobacteriaceae or whatever. So this is studied and this is proved. Dysbiosis happens in children with constipation. وعشان كده جت الفكرة if I am able to modify the microbiota, could this be a potential solution for cases of resistant cases, of course, with chronic constipation? In literature, بيقول yes. And in adults, they have extensive studies on fecal microbiota transplantation in adults with intractable cases of constipation. And actually, if you look in the literature, there are 2 or 3 clinical trials for the pediatric age group looking at the effect of fecal microbiota transplantation in children with severe refractory resistant constipation. يعني كسايد واي كده من ان انا ابعته لسيرجيكال decision. The current evidence للuse of probiotics، يعني لو انا البكتيريا بتاعتي وحشة، طب what if I give you the good bacteria, probiotic a living microorganism. If I give you the good bacteria, الموتيليتي هتتحسن. يعني evidence I would say not very strong. الميتا analysis of 2020 بيقول looking at 8 randomized control trial بيقول lactobacillus rhamnosus مش أي نوع، أنواع معينة منها because this is strain dependent effect might have an effect مش لوحدها بس might have an effect in improving intestinal motility. Our practice in Ain Shams University بيقول إيه في pediatric gastroenterology clinic? Yes, we do use probiotics مع إنها مش evidence based. We use probiotics مع ال dietary interventions مع laxatives طبعا علشان نحسن شوية colonic dysmotility, but we don't use the lactobacillus rhamnosus because we don't have it in Egypt. We use lactobacillus acidophilus في الماركت، يعني Laxeol Forte هي ده lactobacillus acidophilus الوحيد. Okay, so that's the key messages. Dietary interventions definitely are important, but they shouldn't be your fight. They shouldn't be your front line. Cow milk-induced constipation is increasingly recognized, and microbiota modulation is an emerging, very promising intervention in cases with constipation. Thank you very much.
Okay, thank you.
Mustafa.
Okay, I will.
ممكن؟
Any question? دكتور اسماعيل اتفضل.
طيب. Thank you, Dr. Marwa, for your presentations, and I have 2 comments. First of all, I am happy that you said that the dietary manipulation is not a front line, and it may not be essentials because the card that you presented with the types of food that is essential for dietary manipulations will be very frustrating for our children and their families. I don't know if you know about avocado or not. So this is very important and very interesting.
Yes.
Number 2, about the microbiota,
Yes.
because as well, the one who is hearing your lectures will say that the microbiota or the intervention using the microbiome is of
No value.
potential benefits in the futures.
Yes.
Actually, a position paper by the pediatricians has said that the only evidence about the non-medical treatment or the medical treatment for constipation, there's no evidence that anything is the best. The only evidence is that the microbiota has no role in constipation.
Has?
No rule in constipation.
Yes, I just said that it's
yeah,
not in the guidelines.
Yeah,
but
yeah, that's
it is of help.
yeah, yeah. But because sometimes when we يعني if I don't know this, I may say that because we are always attracted to the new terms and new drugs and new things. And by the way, as well, the microbiota have been studied in Hirschsprung disease, especially in the pull-through patients, and had no rule. This is very important because sometimes we may say that, and you know the underlying commercial.
Yes, definitely.
Thank you very much.
All tongues speak microbiota. قد ايه هي effective? I think we still need to study more about it.
Okay, thank you.
I don't know, can you hear me? Thank you again for.
Thank you, Dr. Sharif.
It's my first time to meet you. I'm
Yes,
really
me too.
impressed. I have to say that.
Thank you.
I have one comment only and one question.
Okay.
The first comment is about. I really like how you stress the importance of good doctorship.
Yes.
And employing common sense and treating patients in the background of what we have here in Egypt. And this is very important. Treatment is, as always, has to be tailored to the patient, the family, the environment, the community, and what you have to offer.
Yes.
That's one. I'm just coming to my second question. We know from evidence outside, Cochrane Review 2016, that we have no, according to them, with low quality studies, and one RCT it wasn't included, of course, in this review, that there is no role for dietary modification and there is no role for probiotics, hands down. But I'm asking a question. All these are Western-derived studies. Are the bacterial flora different in Egypt than outside? I would argue to say yes.
Definitely.
I would say yes.
Yes, definitely.
The fact that Lactobacillus acidophilus is working here, it works. In my experience, around 1/3 of the patients is a good proof of this. So one, it's very important not to take anything as is and apply it or take it as, it's important to consider, but always think about your local conditions.
طبعا.
And the second thing, this is a question actually. We all have this, I don't know, illusion that most of the Mediterranean region has lactose intolerance. Is this true or not, in your experience? In my experience, it is for milk intake. Sometimes it works with some kids, and especially in the higher socioeconomic status, and sometimes it worsens the condition. So in your experience, is it really common as it is said or not?
Okay. Answer?
Please.
النقطة اللي حضرتك اتكلمت عليها ان الميكروبيوتا signature عندنا in our population is definitely different.
Signature,
yes, and
I like this.
we are having a research going on في الوحدة بتاعتنا ما بيننا وما بين clinical nutrition على الميكروبيوتا signature في عيانين chronic constipation. مش مختلف بس من مصر وبره، مختلف عن الولاد اللي بتاخد لاكتيفز والولاد اللي ما بتاخدش. I believe in this work will be إن شاء الله بإذن الله good thing. الحاجة الثانية، هل الميديترينيان region فيها high incidence of lactose intolerance؟ Definitely yes. السكندنافيانز هم اللي ما عندهمش lactose intolerance، لكن yes in the Mediterranean area we do have lactose intolerance starting من الأولاد اللي عندهم 5 سنين on. Activity of the lactase enzyme shows some decline. المشكله الاساسيه مع اللبن انه ممكن يعمل الرو ميلك اللي جاي من حتت احنا ما نعرفش هي ايه، او مزارع الحيوانات فيها متربيه ازاي، او بتاكل ايه، او وات ايفر، او بتاخد انتي بايوتكس شكلها عامل ازاي عشان الاماونت اوف ميلك سبلاي يزيد كتير. فميلك is not only about the protein or the lactose, it's about حاجات تانية كتير causing disturbance في الجي اي احنا ما نعرفش هي ايه. Sometimes I'm having problem with milk which is not related to the protein and it's not related to the lactose, it's related to حاجات تانية كتير back to the breeding of the cows itself.
طيب حاجة أخيرة برضو بالنسبة لقصة dietary modification.
أنا I did not expect بصراحة إن أنا هتسأل الأسئلة دي كلها.
لأن ده شغل إحنا بنشتغل نفس الشغلانة على فكرة، يعني ناس كتيرة بيشتغلوا معاكي نفس الشغلانة، دي الفكرة. قصة dietary modification برضو أنا بحط عليها تحفظ لأنه الباك جراوند بتاع الدايت هنا في مصر وفي اغلب الدول الفقيره مختلفه عن هناك.
صحيح.
حتى هناك لما بيبقى فيري باد على الاقل الطفل بيقعد فتره في المدرسه بياخد بالانس
صح.
دايت
بياخد الأكل
كواليتي.
كويس. صح.
عندنا احنا هنا في مصر زي ما تفضل
صح.
دكتور اسامه مش هوصف له افوكادو او حتى دلوقتي احنا بنتكلم في الملوخيه حضرتك كيلو ب 25 جنيه. يعني الناس اللي عارفين يعني كيلو ب 25 جنيه.
لا الفروزن ب 40 على فكره فيعني
ساعات يعني فهماني ازاي العدس دلوقتي على اساس ان هو انسوليبل بقى غالي خلاص. الفول حتى لو كان اكل الغلابه زي ما بنقول دلوقتي بقى بقد ايه وهو سوليبل معايا. فبالتالي I think there is a definite role in our environment for this.
ما انا قلت ان احنا مش لازم نزود في الدايتري بس على الاقل نتاكد انه بياكل كويس.
نتاكد ان هو بياكل المينيمم. المينيمم يعني
True.
دي النقطه وانا اسف للاطاله. شكرا دكتور.
Okay, we can take one more question. One more.
Thank you very much for your excellent presentation. It has been said that probiotics have no role in treatment of in functional constipation. My question is about the role of probiotics in UTI associated with chronic constipation. Is there a role for probiotics to reduce the incidence and recurrence of urinary tract infections that are very prevalent in patients with functional constipation?
اوكي يعني انا هجاوب على الحته بتاعت الكونستيبيشن يا دكتور. الرول يعني او لا هجاوبهم سيبريت. الرول اوف probiotics في المانجمنت اوف repeated UTIs in general in the pediatric practice من غير الكونستيبيشن. repeated UTI في position paper كامله للناسبيجن على اليوز اوف UTI in pediatrics in different situation. البروبيوتكس في اليو تي اي nothing is identified في recurrent UTI which is not related to constipation. This is the guideline. I'm not a nephrologist فانا I will not go deeper here. بس لو انا اديت probiotics لعيانين الconstipation although the evidence says that there is no much improvement لكن حطيتها في البلان اوف مانجمنت مع الحاجات الثانيه والconstipation اتحسن هل ده probably هيحسن repeated UTI؟ I believe it will. ودكتور شريف كان قايل لنا في البرزنتيشن ان المانجمنت goes hand in hand. ف if I improve the constipation I'll probably improve the repeated UTI.
Thank you.
Okay, thank you, Dr. Marwa. For the sake of time, and Dr. Ahmed Bassouni is looking at me. So, okay, let me introduce our next speaker, Professor Dr. Leila Rawash. She will give us some insights about contrast enema and transit time in functional constipation. تفضلي دكتور ليلى.
صباح الخير يا جماعة. I'd like to thank the pediatric surgical department for inviting me today to give this talk, and I'd like to personally thank Dr. Ihab and Dr. Ahmed Bassouni and Dr. Amr Zaki, the organizers today. Today I will give a talk about conventional imaging. These are the three main things that are done for chronic constipation by conventional imaging, either the plain X-ray, contrast enema, or transit time study. The plain abdominal X-ray. I never realized that chronic constipation has such controversies with it until I started researching this in detail. Even though I see this daily, many cases. So it seems like the chronic constipation is not standardized, and it relies on interpretations, especially in X-rays, because plain abdominal X-ray is the most common imaging done in our hospitals and in many hospitals for emergency room. A patient coming, like Dr. Osama said, patient coming with abdominal pain, what do? Go and do erectile supine. In the clinic, the patient is complaining about constipation, abdominal pain, this. Go and do a plain X-ray. So it's done, but when I was researching, there's no definite gold standard to go behind. It's all relative. So it's plain abdominal X-ray. It's good for cases where there's conflicting history, there's difficult examination, and this kind of thing, okay? Several scores have been done over the years to characterize chronic constipation, but so they're not used. And If you ask me, they're very tedious, because if you're writing so many x-rays a day, you've got to start 0, I'll show you later on, it's very tedious. So, but the basis of these scores are the more fecal matter, the more distension, the larger caliber, the more likely it is constipation, okay? This is the BLETH scoring system. Let's see. As you see in the normal, normally there can be some fecal matter in the ascending colon and some in the rectum, okay? The more the patient is constipated, the more fecal matter they'll have. And then if it's over, that's constipation by itself. If it's long-term, it will cause dilatation. And the dilatation usually starts distally, rectosigmoid, and then goes upwards to affect the descending colon, the descending, the transverse, and this. And as well, not only that, what I've seen as well is the sigmoid colon becomes so redundant and overlapping, and it can even reach, in severe cases, up to the upper abdomen. Okay, here's another score. Leach score is supposed to be one of the better, when it was compared, one of the better scores. This Leach score, no feces, scant feces, mild, moderate, severe. As I like to tell the residents, mild, moderate, and severe is very relative. Mild, moderate, severe. So these are, all these scores are, I think, I don't know, but it depends on as well who is seeing it. Is it a pediatric surgeon, a gastroenterologist? Their mild, moderate, and severe will be completely different than a general radiologist who sees a pediatric case once in a while. These are all different. But with this Leach score, 9 or more is constipation, and they can have a maximum of 15. Contrast enema. The main objective of contrast enema is to rule out any Hirschsprung disease. And as Dr. Marwa said, it can present late. I've seen even older than 7, 8. I've seen older cases with Hirschsprung, and even it didn't really look like Hirschsprung because the rectum was big, because the patient has been complaining about constipation their whole life, and they've been doing enemas, and they've been doing all this for treatment for constipation. So one of the cardinal signs of Hirschsprung, the small rectum, is gone, okay? But with the contrast enema, it's very important the type of contrast used. The best contrast to be used in enema is water-soluble contrast. But due to the economic and shortages which we've had recently, it hasn't been available. So we have had to change our way of doing things to barium. But water-soluble has to be used in anybody less than 1 year old. And if you're not going to use water-soluble contrast, don't use it. Because I have seen recently a child who had to do a colostomy for acute on top of chronic intestinal obstruction from barium. And they were less than 1 year old. So if there's no water-soluble contrast, don't do it. Don't risk it. Now, over 1 year old, we use barium, but under tight control. Barium has to be very light, and we have to monitor the patient. In the post-evacuation film, the immediate post-evacuation film, if there is a lot of contrast barium still in the gut, they have to do rectal washes. And this is what happens at our hospital. They do, either our nursing team does it, or the pediatric surgery nursing team does the rectal washes, okay? And there is no film 24 delayed in the barium, okay? Here's several cases. As you see, okay. You can see here, there's a lot of fecal matter here, a lot of in the cecum and ascending, and there's significant dilatation of the rest of the colon. Okay, in the AP and lateral rectal films. Okay, lost that. In the AP and lateral rectum films, you can see this, the good size of the rectum, which will rule out Hirschsprung disease, but the massive amount of dilatation of the sigmoid colon, which is overlapping and full of fecal matter, okay? Prone and supine, and the post-evacuation, you can see a significant amount of retained. As well here, in this one, there's fecal matter here, here, here. AP and lateral rectum, they're not that distended, but the sigmoid colon is overlapping, redundant, and in the post-evacuation film, not well evacuated. A patient like this got a wash afterwards, a rectal wash. Okay? Here you go again. There's some in the rectum, some in the ascending colon. You can see here in the descending colon. The sigmoid is hugely dilated, overlapping, redundant, okay? And in the post-evacuation, significant amount of retained contrast, okay? And in all these cases, you could see the colon. This tells me it's been a while, a long-standing thing. Why? Because the loops of the colon are all redundant, overlapping. You know, sometimes when the residents are showing me, they don't know where they are in the colon. They think they're up on the hepatic flexure when it's still only the sigmoid colon. And here, you know, it's like, you know, in a maze looking for how does it go up, how does it go down. We're chasing after the colon. Okay, colonic transit time markers. This is a very good study as well, but there's no gold standard. There's no standardized. It seems it's very expensive. The markers for this study are not here. Nobody gets them. They're very expensive. Okay, but how it is, it's the patient. The principle is you get capsules with radiopaque things inside, whether barium or sometimes people do radiopaque ureteric catheters, anything radiopaque. And they're ingested, and you follow and you take multiple abdominal x-rays afterwards to see how it has progressed in the abdomen, okay? So either you can do a simple one and follow it up on day 4 or 5, or 3 days, a capsule, 20 markers, 3 days after each other, and then you follow them on either day 4 and day 7 or day 7 only. When there is over 20% gone, this is considered normal, okay? The patient must have a good bowel and no impaction, because if it's impacted, it will affect the study, okay? It's usually over, normal mean transit time is usually 32 hours from the patient swallowing it till it comes out. Maximum, 95th percentile, is 54 hours, okay? The limitation, it's expensive. They have to come several days to do it, the patient, which is very inconvenient, and as well radiation exposures. This is Ryback has a nice graph here, how you do it. You cleanse the bowel the day before, and if it's normal after the 1 capsule, take it on day 4 or 5. If 80% are gone or 20% are left, that's considered normal. If not, that's one, and that is the easiest one. If you take 3 days after each other, and then you check on day 4 for 54 hours. At 54 hours, you count. And as well, not only that, where are you see these radiopaque markers. Here, the radiopaque markers are all over the colon, so there's generalized constipation. But in the further one, you can see most of them are pooled in the rectum. So either there is rectal outlet obstruction or retentive behavior. Here again, here's another one. Colon transit time, all around, they're gone. Here, the second image as well, you can see them up here. Spread evenly around the colon as well. The third image you can see, they're pooled in the rectum. So we have to check, is the rectum normal or not? And this should be in the report. Is it evenly distributed or pooled in one area? Check for the rectum or check for retentive behavior. In conclusion, different conventional imaging can be done in patients in chronic constipation, but it shouldn't be routinely done. They are useful where there's vague history, unusual symptoms, or examination is difficult. The main drawback of all this imaging is there is no gold standard, and it is more dependent on who is writing the report, okay? However, experience does help with accurate diagnosis. The most common, abdominal x-rays. Contrast enema is very good to rule out organic causes. And CTT, if it's there, is the best conventional imaging, and you can see yourself how good the evacuation is. Thank you.
Thank you, Dr. Leila. Any questions? Okay. Dr. Tamer, تفضل.
Tamer Ashraf, Mansour University. Thank you, Dr. Leila, for the very valuable presentation. I have a small question about the technicality of doing the transit time study. Usually the cleansing before conducting the study is important, as fecal retention may give false results about the actual transit time.
False positive results.
Exactly. So do you make sure that you completely cleanse the colon before doing the study? How do you do that?
They say what is written in the literature is you make sure there's no impaction. There's not a large amount of fecal matter to impede the movement. Okay, so as they say the day before. This paper said the day before you make sure the colon is clean. Okay. 100% clean, it's not necessary. But you have to, there shouldn't be a large fecaloma or something, which is more, in these patients, we're more likely to find something like that.
So we agree that we need to avoid having any residual like fecal retention before the study.
Remarkable.
Okay. Because
but it's not like
it's a common
an
fault.
endoscopy where it has to be completely clean. It doesn't matter.
Thank you for this presentation. I asking about colon transit time. I am Shihab Al-Khawaja from Al-Azhar University. According to Satish Rao book, he tells that about colonic transit time, we must not do colonic transit time except must be at first diagnosis and exclusion and the treatment of the synergic defecation before doing colonic transit time for this purpose time. What's your opinion?
Colonic transit time studies are not routinely done. These are done only in patients where you've tried everything and nothing is working. So then you go and do colonic transient time. Even these capsules, if it's needed, you have to go and get them special. So it's not a practical test here in Egypt.
Yes.
And even outside, when you read the papers, it's only done in a few tertiary centers in large areas. So even though it can be valuable, it's not routinely done.
Because obstructive defecation may affect the result. obstructive defecation may affect the result.
Yes, and, yeah,
Yes.
obstructive, if he has retention behavior,
Yes.
like Dr. Morrow was saying, the retention behavior, of course it'll give all the markers will be lodged in the rectum, because there's nothing wrong with the colon, it's the active defecation that's causing the trouble.
So not preferred to do it from the start. Sorry, doctor. Not preferred for doing it for the first test for the patient. You not prefer to do it from the first test for the patient?
No.
Okay,
so,
Actually, conventional imaging is not even, it shouldn't be routinely done for constipation. Constipation is usually a clinical diagnosis, and that is enough to diagnose it. When they come for radiology, these are refractory cases, or a case there, the patient's saying one thing one time and the parents or something are saying one thing. It's not a smooth case. There's something going on. They shouldn't be doing contrast enema or CTT or any of these. Only whatever, 1 in a million of these patients should do it. It's not routine.
شكرا دكتورة ليلى. أنا بس عايزة يعني تعليقين بسيط جدا كده. طبعا the conventional imagings are not used for diagnosing constipation, but they may be used for monitoring the effect of the treatment of constipation. This is number one. Number two, about the colonic transit time. This is a very essential study if patients is going to do surgery. What I mean that if you look at the physiological test for constipations in a hierarchy, you will find that the anorectal manometry will come first. And so you will exclude obstructive defecations and dysenergic defecations. But still, as Dr. Leila had shown that patients with colonic transit times, you can suspect the presence of outlet obstruction or obstructive defecations as a mean for or as one of the results of the colonic transit time. Colonic transit time is very essential, as I said, because if you want to do surgery for these patients, you have to classify them into either they are having a normal colonic time, colonic transits, they have total colonic inertia, or they have a localized segmental dilatation and inertia of the colon, because any of these findings or any of these types will have a different surgical approach. I think when we come to the surgical treatment of these cases, we will illustrate these ones. I would like to ask Dr. Leila about the value of the dolichocolon or the redundant sigmoid. The dolichocolon or the redundant sigmoid.
Yeah.
Do you think that this sign could be a good indicators for us to say that constipation is there or not? I mean, yes, now we cannot depend on it, but what do you think that patients with dolichocolon or redundant sigmoids, many studies had shown that most of the constipated patients had these anatomical abnormalities. Do you think that this could be an indicator for the presence of constipations or not?
I think, especially according to age, a dolichocolon in a 2-year-old
It's different, yeah.
is different than a 12-year-old or an adult. Once you find or redundancy, not only in the sigmoid, in the other loops of colon, in younger age group, that's telling me there's something going on because they haven't had time to be constipated. But if you find it in an old patient, not in pediatrics, like an adult or something, it's less significant, in my opinion. But in children, when there's redundancy, yes, this is telling me it's something that's been, the colon is dilated and redundant. That means this has been a long time. It's not just something like the patient's family said, oh, he's only been doing this for 2 months. No, it's been much more than that.
Okay. And can you use the conventional imagings as a guide for your laxative dose?
A guide for what?
Like when we use laxatives for managing constipations, can the conventional radiology images be a guide to how much we have to give these patients?
I would imagine, because I don't treat. you're doing the treatment, but I would say if you find somebody with significant redundancy and with the history, that will, and then you look at the colon, because sometimes patients, the family tell you things and you can't believe it. But when you hear the history and you see the bad looking colon, you'll say, oh yes, this patient has bad constipation. Maybe you will start higher doses. But you know, I don't do treatment.
I don't do treatment. What I have to say,
thank you.
what I have to say that the conventional radiology has a rule,
it has
an important
a rule.
rule in managing cases of constipation.
I never knew it
what
didn't
I,
have
what I
a
like
rate.
to stress, because
I never
somebody
knew.
will say that it has no rule.
Well, according to Rome criteria and the European and all these,
for diagnosis.
they
for
say
diagnosis.
no, just
For
history.
diagnosis.
If I may intervene, just I totally agree with you. I totally agree with you. It's not used on a classic basis or on a routine basis.
No.
In some cases, sometimes you need not only one X-ray. Actually, the importance of this in the actual clinical setting is having a trend. A trend. You do not judge the patient only by a snapshot X-ray within the confines of the ELARA concept. That's one. The guidelines, I agree, the 2014 guidelines, etc., are all, omitting X-rays completely. But they do have a rule. And by the way, despite having a lot of classifications that have gone out of favor, Blithen, Leach, etc., even the paper that addressed this came from a urology journal, by the way.
Yes, I saw that. Yeah.
You see it in 2011, 10, something like that. They used the Leach classification in the beading, the three famous line in the beading. So eventually we are in an area where everything is, jelly-like or blur, and it depends on the clinical judgment of both the radiologist and the treating clinician. And I'd like to thank you. I always consider you part of the team, you and Dr. Shema, or part of our team, actually.
Yes, we're
thank
all
you so
one
much.
team. But what I think is why they say it has no role conventional is because there is no gold standard for constipation and for diagnosis of constipation in radiology. That's why they say, no, there's no role, because you need 1, 2, 3, 4, you need checklist or guidelines. And until now, there is no research. So maybe new research, we can do new research into this. Okay,
thank you very much, Dr. Leila. I want to stress an important point regarding radiation. As in plain X-ray is not diagnostic of constipation, so the request from clinicians to an X-ray should be cautiously thought due to the risk of radiation exposure. It's very risky to repeat the X-rays. It increases the cancer risk, especially for leukemia and hematological cancers. So the radiation exposure should be kept to minimum, as ELARA principle stated, as low as reasonably achievable. So all clinicians should put this point in mind all the time when they are requesting a plain X-ray or even enema or other radiological modality which has an X-ray exposure. Thank you very much. Next speaker, Dr. Mustafa Bayoumi, will talk about value of manometry study in cases with chronic constipation.
First, I'd like to thank all my dear professors for this invitation and a chance to talk about anorectal manometry, and especially thanks to my professor, Dr. Mohammed Debiki, who taught me all the aspects of anorectal manometry and how to do the test and interpret the test. To be more concise, my talk will be about two things, to answer two questions. What is the anorectal manometry? What is the aspects of the anorectal manometry? How to do it in brief? And to answer another question, who is the patient? The most frequent question for all the clinicians asking, who is the patient will need to do an anorectal manometry for? So background, as you all know, the anorectal dysfunction affects quality of life of more than 5% of the population. In the literature, there are a larger spectrum for this percentage, could be up to 30%. The anorectal manometry, in brief, it's a catheter with sensors that record all the pressure dynamics during the defecation act. And through the anorectal manometer, we can assess the anal sphincter length and tone and function. Also the anorectal sensation, rectoanal reflex, either local reflex or the higher reflex. And the ability to squeeze and simulate a process of defecation. So the first value of anorectal manometry is to have a picture what's going on in Hirschsprung disease. Is this patient have Hirschsprung or not? Through measuring the rare, what's called rectoanal inhibitory reflex, which is a local reflex. If any part of this arc, either the afferent pathway, the ganglia, or the relay of the ganglia in the spine, or the afferent pathway or the sphincter, if something in this arc have a problem, so the rare will be absent. So if any patient have a signs suspecting Hirschsprung disease or achalasia, or patient post-operative after rectal myomectomy, or a complex anorectal malformation, we can order anorectal manometer for this patient. Also, post-operative evaluation after certain procedure, after pull-through of Hirschsprung, after biles, after fistula, after a perineal trauma repair, we can assess all the tone and how the dynamics in the anorectum before we either close a colostomy if the patient is diverted or not, or if there is a patient after certain persistent defecation problems after the operations. And if we had a patient with obstructive defecation, like this patient have a normal sensation, he is sensate to go to the toilet, but he had a multiple failed attempt for defecation. This patient may have a obstructive defecation. One of the most common finding in this patient is a dyssynergia. So anorectal manometer is the gold standard to diagnose dyssynergia in these patients. Also to evaluate the efficacy of botulinum toxin in injection for patient with dyssynergia, and also assessment of rectal sensations, spectral tone in spinal cord lesions, sacral agenesis, and fecal swelling, either true or false, and functional in rectal pain, and we can use it in biofeedback. This is the Kester for the test. The Kester have multiple sensors on multiple levels, and at the ends of the Kester there is a balloon. We can inflate the balloon to simulate the defecation or the stool in the rectum, and it either could be a water perfused or solid state. It varies. Water perfused have more cheaper than the solid state, and it use pressure and water for simulating or measuring the pressure changes in the anorectum. Solid state, it's a solid sensors. It records by mechanical pressures, and the probe that contains the sensors. And this is multiple pictures for different type of catheters. The solid states, all of them A, B, C are solid states, and number D is a high definition. And the balloon and the software, and this is the setup. There is evolution over time for the anorectal manometry. The old one, the conventional manometry, our non-high resolution manometry, it gives us the pressure changes through a drum with curves up and down without any color vision for the change in the pressure in the anorectum. And after that, it came the high resolution anorectal manometry, and after that, the high definition anorectal manometry. And in 2020, there's a large groups of gastroenterologists and physiologists came to a standard protocol for how to do an anorectal manometry all over the world to speak a common language between all the persons or physicians who are doing the anorectal manometry. And it came to the International Anorectal Physiology Working Group recommendations for the manometry. And they did the London classification. It's like a protocol to be standard for all the clinicians who will do the manometry. First, we put the catheter and we wait for stabilization till the patient accommodate the catheter. It will take 3 minutes, and after that we record the resting tone for 60 seconds, and after that we take multiple short squeeze like a contraction. بنسأل بنقول للبيشنت يعني امسك نفسك على القسطرة أو كأنك بتريتين الستول أو اليورين، ونشوف الكونتراكتيليتي ونشوف البريشر في الانر سفنكتر. بعد كده بناخد اللونج سكويز، يعني بتبقى فترة أطول شوية، بنشوف how this patient will hold a stool for more time. And after that we assess the cuff reflex, which is a local reflex. And after that we record the push, which is simulation of the defecation. بنقول للعيان اعمل كأنك بالظبط قاعد في الحمام، وحاول نشوف الريكتو انال كوردينيشن اثناء الاكت ده. وبعد كده بنريكورد الرير الريكتو انال انهبيتور ريفلكس. موستلي احنا بننفليت البالون ب 30 مللي to 50 مللي، طبعا according لو البيشنت كبير او في chronic constipation، او بنبص على الكونتور سينما قبل الفحص. لو لقينا الريكتم بتاعه كبير عاده ممكن نعلي الريت، بنعمله multiple 30 40 50 up to 90 milliliters. And after that we record the rectal sensations, and at the end we do the balloon expulsion test. بنفليت البالون 50 مل ونقول للعيان انت معاك 30 to 50 seconds to expel the balloon and the catheter. في نهايه التست احنا المفروض بنوصل لاربع حاجات. يعني هو بنكلاسيفاي الديس اوردر اللي عند العيان، هو حاجه من الاربعه دولت. Either the patient has a disorder of the erectoanal inhibitory reflex. It could be Hirschsprung, it could be achalasia, it could be any part of the arc of the local arc يعني that we previously talked about. في affection or في problem هيبقى في عندي disorder of rectoanal inhibitory reflex. Second disorder will be the anal tone and the contractility. لو في patient عنده perineal trauma، أو لو patient طبعا post Hirschsprung repair transanal من الدايلاتيشن حصل ان هو في الكونتراكتيليتي بتاعته اتاثرت. الحاجه الثالثه ان هو disorder of anorectal coordination اللي احنا بنشوفه اثناء البوش. لو في ديسونرجي هتبان، وبنقول ان هو في عنده abnormal coordination. وفي الاخر disorder of rectal sensation. طيب يعني هندي بس كيس سيناريو، حاجه بسيطه خالص. احنا يعني هنقول الكيس دي جات لنا، وهوري حضراتكم اللي بيظهر معانا في التست ايه. That 10 years old male patient presented with chronic constipation since the age of 7 years, and he had a rectosigmoid resection somewhere with transanal pour through. Not for Hirschsprung, most probably, because I saw the pathology, and then leakage and colostomy formation, and then closure of the stoma after 6 months. And this patient still have the same problem of constipation with partial improvement. The patient had 2 years of biofeedback training, partial improvement, tried Botox, partial improvement with no definitive treatment for his case. ده المنظر ده انا عايز اوري حضراتكم احنا في التست ده اوكي. طيب احنا في المنظر، خلينا ممكن البوينتر بس مش شغال. طيب احنا لو بصينا على الصورة اللي قبلها، اوكي، هي دي المشكله اللي عند العيان. هو احنا ده اثناء البوش بنقول للعيان يسيميليت الديفيكيشن. فما قبل الشريط الاخضر طبعا هو ده سيت اب يعني بيبقى ظاهر عندنا. الكالر زون هو اللي بيديني ما فيش
بص يا مصطفى خد الميكروفون.
طيب اوكي،
عشان ده مهم الحقيقه.
اوكي طيب طبعا ده الكالر سكيل.
وده بوينتر.
ما هو لا هو طب اوكي خلاص ماشي. اوكي
صلحت لك
طيب هو يعني ده المنظر بيبان لنا يعني في الكمبيوتر. ده الكالر سكيل اللي بيبين لنا البريشر فروم زيرو بيبقى اللي هو الازرق خالص لحد ما بنوصل لحد فوق ال 170 ده اللي هو اعلى بريشر خالص اللي هو اللون الاحمر القرمزي اللي فوق. فده بيدينا كلو. طبعا اللي في النص ده الريستنج تون ده في بدايه طيب البوينتر شغال فوق.
البوينتر مش بتبان.
طيب بالماوس بقى. طب ده شغال الماوس بتاعه؟
بس ده مهم عشان نعرف نتكلم عليه.
اوكي. ممكن بس تشغل لي البوينتر هنا من على لو شغلت لي بوينتر من على اللابتوب ما عشان يظهر عندهم كمان. طيب خلاص مش هينفع. طيب اوكي. طيب اوكي هشاور هنا وهشاور هنا. اوكي. فانا كنت بقول ان ده الكالر سكيل بتاع البريشر. كل ما كان اللون ازرق اوكي هشاور هنا الاول. انا شرحت هنا هشرح هنا. كل ما كان اللون ازرق طبعا كل ما كان ده البريشر تورد زيرو وبعد كده بيعلى البريشر لحد ما يوصل ل 170 اللي هو اعلى حاجه خالص في البريشر. اللون الاحمر القرمزي ده اللي هو بيبقى من الجنب هنا. ده بيبقى اللي من الجنب هنا خالص. طيب هو مبدئيا بيبقى ده الريستنج تون وبعد كده ده الريستنج تون في الانال كانال واللي فوقيه بيبقى الريكتم. يعني هو هنا حتى لو حضراتكم شايفين البوكس الاحمر ده اللي بيريكورد البريشر تشينجز في الانال كانال. بعد كده الحته اللي فوق دي ده الريكتم. ده اللاين بتاع الريكتم. ولذلك هنا اهو ده البوكس ده اللي بيريكورد الانال كانال وده اللي فوق بيشوف الريكتال بريشر تشينجز. باجي بعد كده بقول للعيان او سيميوليتد ديفيكيشن فبيبتدي يعمل البوش اكت فبيبتدي عندي الريكتال بريشر يعلى زي ما حضراتكم شايفين. ما كانش فيه موجود قبل كده كان ازرق بعد كده ابتدى يبقى في البريشر بيعلى في الريكتم. طول ما البريشر سكيل ده اللون اخضر او بريشر هو بيديني هنا الريكتال بريشر الماكسيمم ريكتال بريشر اللي وصل للعيان اكتر من 15 هو حاطط ده اكوردنج او ده سيت اب هو جاي بيه. يعني هو ده اللندن بروتوكول ان هو بيقول للعيان ده لازم اكوردنج لايدج البريشر في الريكتم يعلى اكتر من 15 اللي هو اللور ليميت اوف نورمال بتاعه. فهو هنا العيان هو استيميتد ان هو وصل ل 55 ملم ميركوري. فده بالنسبه لي بروبالسيف موفمنت كويس. العيان ده ما عندوش مشكله في البروبالسيف موفمنت بتاعته. لكن المفروض بيحصل اثناء الاكت اوف ديفيكيشن ان الانال كانال بريشر يقل. اللي بيحصل ان الانال كانال بريشر بتاعه بيعلى زي ما حضراتكم شايفين. المفروض ان هو بيريكورد الحته دي كلها على بعضها ويديني ان الانال بريشر بيديكريز اقل من الزيرو ولا لا. لو طلع يعني هو كام عالي اكتر من الزيرو خلاص عشان اعرف اللي كان الانال بريشر بتاعي نزل ولا لا. العيان ده عنده ديسينرجيا تايب 1 اللي حصل وهو اثناء الاكت اوف ديفيكيشن. اوكي كويس قوي. اوكي كده كويس. تمام شكرا. خلاص اوكي شكرا. ممكن اشتغل بالليزر بوينتر. اوكي. فهنا البيشنت طبعا اثناء الاكت اوف ديفيكيشن هو الريكتال بريشر بتاعه عالي وصل للون ده واحنا تحت حتى السيستم اسهل ان هي 55 which is above the lower limit of normal. ده كده العيان ما عندوش مشكله في البروبالسيف موفمنت بتاعته. لكن هو عنده مشكله ان تحت الانال كانال بريشر ما بيقلش معنى كده هو عنده اوبستراكتيف ديفيكيشن. ولو جينا بصينا هنا ده 3 دي ريكونستراكشن بيبان لي قصادي المشكله فين انهي بارت من السفنكتر كومبلكس. هل هو طبعا الفرد تحت يعني ده بيديني مثلا تحت ده الرايت كومبارتمنت الانتيريور كومبارتمنت وهنا البوستيريور كومبارتمنت الناحيه الثانيه بتبقى الليفت. فهنا العيان ده عنده مشكله في الانتروبوسترو انا اسف الليفت بوسترو بارت اوف ذا ماسل كومبلكس. هو عنده مشكله ان السفنكتر في البارت ده ما بيريحش. هو ده اللي بيعمله الاوبستراكتيف ديفيكيشن. انا المفروض الاقي ان اللون الاخضر ده ينزل شويه يبقى ناحيه الازرق شويه. فانا بعرف ان هو عنده مشكله في البارت ده. حتى لو العيان ده احتاج ان احنا بعد كده ممكن اعمل له بوتوكس ابقى انا عارف في البارت ده انا محتاج احقن اكتر من اي بارت تاني. يعني بيديني كلو. فالعيان ده في الاخر هو عنده تايب 1 ديسينرجيا بتعمل له اوبستراكتيف ديفيكيشن. ف هو محتاج ان هو يكمل على البايو فيدباك، محتاج يدي كمان ترايل بوتوكس تاني. ممكن في المره اللي هنحقن فيها بوتوكس المره الجايه نبقى نحقن اكتر في البارت ده اكتر من اي بارت تاني. وطبعا يعني عشان برضه اوري حضراتكم مهتمين جدا ان احنا نعرف طب ممكن اقلب، مش بيقلب. اوكي. لما جينا نبص على الريل في العيان ده برضه عشان هو عامل الريسكشن فور هيرشسبرانج ديزيز طبعا، والباثولوجي لو جينا قريناه كويس هو مش ماشي مع هيرشسبرانج ديزيز، بس هنا الريل بتاعه بوزيتيف. طيب هو ممكن اصلا الريل يبقى بوزيتيف في العيانين الهيرشسبرانج في الليتريتشر بيقول ان هو عيان بروفن باي باثولوجي ان هو بيطلع عنده ان الريل بوزيتيف، ده مش شرط اكيد. طب هل لو عيان عنده رير نيجاتيف وعمل بول ثرو في الهيرشسبرانج، هل لما اجي اعمل له ان ريكتال مانومتري بعد العمليه هيبقى عنده الرير ابسنت؟ ما هو خلاص ما انا شلت اصلا الريكتم، هو المفروض يبقى لا. في الليتريتشر بيقول لو حتى في certain procedure زي سوافي بيلاقوا ان 34% من العيانين عاملين سوافي بيبقى عندهم الرير بوزيتيف ايفن حتى لو هو كان قبل العمليه كان رير نيجاتيف. تمام. وده النتيجه لايه؟ لان هو مش بس الجانجليا هي اللي يعني بتدي يعني بتساعد في الرير، لا كمان في حاجه البلفيك ريسبتور ستريتش ريسبتورز كمان بتخش تساعد في موضوع الرير، هو ده اللي بيكمل اللوكال ارك بتاعنا.
معلش يا مصطفى بس انا عشان يعني هنا not to confuse the situations. Actually if the patient has SWAV he has no rectum, so you are not looking for the rare. The rectum is not اصبر بس. The rectum is not there, so it is not a rectoanal inhibitory reflex. It's what's called coloanal inhibitory reflex. It's something different. This is very different. يعني ما اقدرش اقول ايه ان sometimes if the rare is not there, if the rare is not there, this means that this is a Hirschsprung disease. تمام. And then you have to confirm this with a biopsy. If the biopsy is no ganglia, this is Hirschsprung disease. If there is ganglia, so we have internal anal sphincter achilles.
حضرتك توتالي رايت طبعا في اللي حضرتك بتقوله.
انا بقول لك يعني بس عشان نقطة الحاجة الثانية معلش. If we find that the circumference of the sphincter is not homogeneous, this means that the surgery had affected part of the sphincter. That means these patients had a sphincter affected. انت لا يمكن انت بتتكلم على في تو ريفلكسز هنا الحقيقه. في واحد internal sphincter reflex and this is the rare, and another reflex which is called external sphincter anal reflex. The external sphincter, although it is a skeletal muscle, but sometimes it works in a reflex way. تمام؟ فلو انت عندك الدنيا كلها مش complete بالانوريكتال manometries, this you have to confirm that the sphincter is complete. تمام؟ لان انت if it is reflex مش معقوله حته من السفنكتر هتشتغل وحته مش هتشتغل.
انا بقول لحضرتك ليه المنظر ده بنشوف في العيانين اللي مش عاملين سيرجري.
لا معلش انا بقول لك يعني المنظر ده في العيان ده عشان اعمل سيرجري.
لا حضرتك لو بتتكلم انسرت يعني على البيشنت.
الحاجه الثانيه بقى المهمه يا جماعه عشان بس نخرج بحاجه من الكلام ده، ان انت before you do the surgery for constipation you have to confirm these findings. You have to confirm that you do the colon transit time. You have to do anorectal manometry because these patients would be treated simply by Botox, biofeedback mechanism, whatsoever. The resection that you did and the pull through that you had done was wrong. ده مهم جدا بس عشان ايه؟ يعني احنا نبقى فاهمين هو الانوركتال مانومتري بس تعمل في وقته. ما ينفعش انت تيجي بقى عيان عمل اوريدي وعيان نيجي نكتشف ان هو العيان يا عيني كل الديزاسترز دي حصلت له وهو اصلا he had functional problem. مش كده؟ مش كده يا مصطفى؟
مظبوط يا مين صح. ثانك يو. اتفضل.
Thank you, Dr. Mustafa, for this presentation. I will ask you about anorectal manometry. I have experience in doing it. According to REER, you speak about if REER positive, they didn't exclude Hirschsprung, but it is good, very good predictive test for exclusion of Hirschsprung disease if the rear is positive, because there is ganglia and there is muscle acting, there is reflex, so it's no Hirschsprung disease in this patient, okay? And this depends on the percentage and the type of length of the rear. If percentage is more than 50%, okay, it is good. Maybe planted rear due to other causes such as megarectum, hyposensation, or doing myomectomy, or spinal injury, or other causes may affect the rear, okay? But if the rear positive, it's good exclusion for Hirschsprung disease, and this is what we find.
مظبوط اللي حضرتك بتقوله،
This
بس
is-
انا هزود عليك حاجة. هو دلوقتي 25% decrease في الانر بريشر مش 50%. يعني انا اقصد accepted ان احنا بنعمله. في جزء كمان من ال يعني هم عاملينه في الجهاز ان انا هشيل كل الريكتال بريشر اللي موجود علشان مجرد انا اركز بس مع الانال بريشر. علشان كده بقول لحضرتك ان هو بينزل لحد 25% وتقدر تشوفه بعينيك مش بس تريكورد.
Okay. The second question for you about the synergic defecation, and we can assess the 4 types of synergic defecation by anorectal manometry. But what's the role of intervention? What's the role of anorectal manometry in diagnosis and next step after diagnosis of this patient has the synergic defecation? Because a lot of patient has the synergic defecation, but they have weak squeeze, يعني weak squeeze plus the synergic defecation. So this patient is not doing biofeedback is for this patient is the good. Can you choose the criteria for biofeedback?
في وانا بمناسبه التايبس بتاعه الديسنرجيا في حاجه اسمها رؤوس كلاسيفيكيشن، هو اللي يقول لي التايبس بتاعه الديسنرجيا دايما بنرجع لها نشوف هو انهي تايب. زي ما انت بتقول هو ممكن يكون اصلا عنده ويك سكويز بس هو اولسو برضه عنده ويك بروبالسيف موفمنت، هو انهي واحد من دول. فانت كل ده انت بتشوفه، يعني الانوركتال مانومتر يعرف يديك بيكتشر هو انهي واحد من دول، واكوردنج انت بتتابع العيان ده موست بروبلي ممكن يحتاج مع الباول مانجمنت ستيمول اكسس محتاج بايو فيدباك. انت بتشوف العيان تاني وهو بيعمل بايو فيدباك ويرجع لك تاني وتعمل انوركتال مانومتري، انت بتشوف التشينجز دي. العيان برضو العيان اللي بيبقى عنده ديسنرج تايب 1 وبتحتاج ان انت تحقن له بوتوكس، لما يجي لك تاني تشوفه بالانوركتال مانومتري بتشوف الافيكاسي بتاعت يعني انا اقصد
كل ده بيديك you inject this patient the synergic defecation with weak squeeze, you inject botox?
انا
Yes, because you have 4 types of dysynergia.
Yes.
You may have good contractions or high pressure in the rectum with an increased pressure or squeeze pressure, as you said, or failure of relaxation. So the resistance is not only because of increase in the pressure in the anal sphincters. Sometimes the anal sphincters fail to relax. You will not find an increase in the pressures, but you will not find relaxations when the patients had an increase in the pressure in the rectum. So it depends on the type of dysynergia that you are facing or having.
This is the types of dysynergia, Dr. Osama.
Yes,
This is the types of dysynergia, but defective relaxation didn't mean the patient has good power of squeeze.
No, we didn't. If I understand you,
Yes.
you say that there is no increase in the squeeze pressure. The patient, it's not the squeeze pressure, it's the resting pressure. There is no increase in the resting pressure when you stimulate. What is happening when you stimulate the rectum? The sphincter should relax. Sometimes it will not relax, but even there will be an increase in the pressure in the anal canal. This is a different 2 types of dysynergia.
This is a spasm. This is a spasm.
No, it's not spasm, it's called failure of relaxation. There are 4 types. One of them is failure of relaxation of the sphincter.
Okay, thank you.
يعني تفضل يا بيه تعالى.
Thank you, Dr. Mustafa, for your elegant presentation. I want to ask about the focal affection of the sphincter, as you mentioned. Was it post-operative finding?
Yeah,
You mean there is an injury of the sphincter or something?
يعني it's a year beyond the surgery بس.
One year post-op.
هو العيان عامل سيرجري تقريبا عند سن 7 سنين، هو كان جاي لنا وهو عنده 10 سنين، يعني بعد 3 سنين. انا ما عملتلوش انوركتال، ما عملتلوش MRI علشان اشوف اذا كان في مشكله فعلا في السفنكتر ولا لا، بس هو الاكزامبل ده احنا بنشوفه ايفن في العيانين حتى اللي مش عاملين اي سيرجري خالص. يعني فكره ان اني بارت يعني السينرجي هل هي بتاخد اني بارت، ايفن حتى كمان ممكن اشوفها على الليفل بتاع الاكسترنال سفنكتر او انترنال سفنكتر، هي حاجه اوبجكتيف شويه، مش يعني مش حاجه كونكلوزيف، بس بنقدر نعرف ده على الليفل بتاع انهي سفنكتر. ده لو عيان ما عندوش هيرشوز بانج او ما عملش اي بول ثرو او ما عملش اي عمليه خالص. بس فكره ان احنا نشوف انهي بارت بالفرد ده 3 دي ده يقدر يقول لي.
وممكن يكون جزء بس من السفنكتر مش كله افكتد زي ما انت قلت فوكال، يعني حاجه فوكال
بالظبط.
تمام.
دكتور مجدي بيه.
Thank you, Dr. Mustafa.
Short question.
I think the use of manometry has many limitations and diagnosis and management of chronic constipation. First of all, إنه limited study يعني before 2 years or more، لأنه you need the interpretation of a cooperative child. Is not cooperative child I cannot use يعني because I cannot ask the baby to squeeze and to relax and to strain. It is limited. Second question is that you demonstrate a spectrogram. This spectrogram, I think, يعني it's used يعني mostly in injury of the external sphincter, because if I ask the patient to squeeze or to strain, now I assess the external sphincter and not the internal sphincter. So it's used only for injury to decide what part of the external sphincter injured, and I cannot do repair for that injured part. يعني. Third question, you mentioned the term of obstructed defecation. Obstructed defecation, as I understand, it's mean that the pubic talus fail to relax, and is not يعني the term to use for achalasia or for the stricture of the external sphincter.
The term
fissure
is obstructed defecation syndrome.
Yeah.
So you have all these under the same term.
But for chronic fissure يعني in pediatrics.
أنا فاهم، بس أنا بقول لحضرتك يعني إحنا when you talk about the obstructed defecation you are talking about a syndrome that can include all of these.
But
findings.
in babies we use the term of obstructed defecation and مثلا a spasm of the
still it's an obstructed defecation. يعني the patient، ما هو ده فايدة يا جماعة الخير البالون expulsion test. If you are failing to the balloon expulsion test, you have an obstructed defecation. If you succeed the balloon expulsion test, you you have no obstructed defecation. أنا بس لو تسمح لي مصطفى رد على حضرتك بالنسبة للرول اوف ذا مانومتري. الحقيقة عشان بس نبقى عارفين anorectal manometry there are 3 parameters that you are measuring: the rear, pressures, and defecation dynamics. You can do anorectal manometry in day 1 of life, but you cannot make a comment except on the rear. Yeah. And as you said, it is dependent on the age and the patient is toilet trained or not. If before 4 years of age, you may not have the pressures, the squeeze pressures and the expulsion, even the balloon expulsion tests. And even if you have more than 4 years, you have to know that there is a group of patients who are said that they are what's called neurodiverse, the autistic patients and psychological behavioral problems. Those patients as well, the anorectal manometry parameter that you can measure is not the classic ones. So you have to differentiate between the different ages, the different types of patients, and you can say, I am doing anorectal manometry, but you have to define and determine what are the parameters that are you going or are you able to measure in these patients. Thank you.
Thank you. Last short question.
Next.
One short question, please.
معلش.
One short question. Thank you, Dr. Mustafa, about this good presentation. My question is about the photo that you presented for high definition or high resolution manometry. you detect there is a problem in certain site of sphincter, of anal sphincter. Can you have these results by traditional manometry, or you must use high resolution manometry?
انا ما اشتغلتش كونفنشنال خالص، هو اللي اشتغل استاذي دكتور محمد الدبيكي وهو واقف اهو، ممكن تسال السؤال.
Because in Mansoura we have the traditional one, we didn't use high resolution.
بص هقول لحضرتك
use ultrasound and you will find any ultrasound يا راجل.
Endorectal ultrasound.
If not available خلاص بقى.
بس حضرتك مش هتعرف تشوف
دكتور عصام. دكتور
اسماعيل.
واحد يا باشا. شكرا دكتور مصطفى على البرزنتيشن الجميله. انا بس I have a very quick comment عن السيرجيكال بارت على الكونستيبيشن، و I know this will be covered later on، بس في عشان الكونتكست اللي حضرتك قلته. many surgeons tend انه يعملوا resections which is not needed. وده الرول بتاع اللي حضرتك قلته، الرول بتاع الانوريكتال مانومتري والكرونيك مانومتري، and these should be done prior to any surgical resection لاي كولون. لانه in many cases the problem is dyssynergia or problem dysmotility، ممكن diffuse colonic inertia او rectosigmoid dysmotility، وده مش هتتحل بمجرد resections. يعني we tend to see so many patients عاملين colonic resections for nothing without any testing. Just in a patient, he's not Hirschsprung, let's remove the colon. That's a very critical point. The dyssynergia would need, according يعني زي ما حضرتك قلت, would need biofeedback, would need Botox. بس السيرجيكال رول is very limited even في البيشنتس دول. بعد ما احنا نتراي الاول ان ممكن انتجريت اكسس، وده has been proved by randomized controlled trials انه الانتجريت اكسس would negate the need for any surgical resection in more than 90% of patients. Only less than 10%.
In the localized form.
What's that?
In the localized dysfunctional of the colon. It was a tradition that you go and resect because there is a localized dysfunction in this part of the colon. But the anti-grade colonic enemas had been proven to be of value even in this patient, but you have to persist on that. An important thing دكتور اسماعيل عايز اقولها ان انت الحقيقه هو even if you have a dyssynergia and you have as well a colonic transit problems, the choice of the surgery can be guided by these tests. I mean, you may not only do resection surgery for these patients, but you may need as well to help them how to expel, how to evacuate they have a good now colon because you resected the dysmotile, but you should assess them with another means to help them to defecate, to avoid the obstructive defecation. Either you give Botox, biofeedbacks, or even you add with the resection the anticolonic grade enemas, the ACE techniques.
بالظبط زي ما حضرتك قلت، لو في patients عندهم dyssynergia وهيتعمل colonic resection it's very different than patient ما عندوش dyssynergia وهتعمل colonic resection. It dictates actually التايب السيرجن اللي انت هتعملها. هل انت مجرد هتعمل resection مثلا واليو anal pull through، ولا هتعمل just مثلا resection وديلوير مع anti grade enema. It's completely different. فده الفاليو بتاع
complete agree with you. ونفسنا بصراحه الكولونيك مانومتر يخش مصر برضه
هو يعني limited للاسف
يعني at the time ان شاء الله.
شكرا جزيلا. I have the honor to present our dear colleague Professor Shamea Absattar. She is our reference for pediatric radiology by the mean in Ain Shams University, not only for the pediatric surgeons. If we have any difficult case, we assign her by name. We don't say we need a second opinion. We need Dr. Abdusattar opinion. She's going to talk for us about the MRI defecography in children and adolescents. Please, Doctora.
Thank you very much, Dr. Osama, for introduction, and thanks for invitation. I will talk about MRI defecography in children and adolescents, and this topic is rarely written in literature. Most of the papers discuss this topic especially in old females or adults with colonic constipation, and I will talk about our experience in Ain Shams University. I will talk about MRI anatomy of the pelvic floor, indications of MRI defecography, its technique, and finally case demonstration of various pelvic floor disorders encountered in Ain Shams University. Pelvic floor anatomy, as we all know, starts with the levator ani muscle, is the main muscle of the pelvic floor. It's formed of various subdivisions. Puborectalis is the main muscle of the pelvic floor surrounding the rectum and the anorectum, and iliacossogeus muscle in here in light green. Puborectalis is in dark green, and pubococcygeus in also surrounding the puborectalis. And regarding the MRI anatomy, this is a sagittal T2 weighted image. This is sagittal T2 fluid in lunar bladder appear as bright signal, and this is rectum and anal canal here, and this is various muscular subdivisions. This is the external anal sphincter here, and this is the puborectalis, and this is the levator plate. In axial section, we can see here the anorectum here, surrounded by the puborectalis muscle inserting into the symphysis pubis. Also, this lower down at the level of the ischial ramus, we can see the anal canal, and this is the transverse perineal muscle here. In the coronal plane, this is the iliacossogeus muscle in number 4, this is the iliacossogeus, and number 6 is the transversus perineal muscle. Number 2 is the rectum, and number 1 is the anal canal. MRI difficography indications difficulty of rectal evacuation, incontinence, pelvic floor pain, or bleeding per rectum. Patient preparation, the child should be cooperative, usually above 8 years of age. No specific preparation apart from those related to general MRI examination, explanation of the technique to the patients and the guardians, and finally injection of rectal gel after acquiring the basic sequences. This is the static images before injection of the rectal gel. We can see here the sagittal, coronal, and axial sections to demonstrate the MRI anatomy of the pelvic floor muscles and figuring out any abnormalities or any mass lesions present in the pelvis. Also, the static images are acquired after intrarectal gel injection in the same planes, sagittal, coronal, and axial sections. Also, axial stair T2 fat suppression sequence and axial T1 are acquired to demonstrate any associated or characterize any associated pathologies that could be encountered. Dynamic images, classically speaking, are acquired at rest and squeezing with doing Kegel maneuver and during straining or valsalva and defecation. But actually in children, especially in young 8, 9, 10 years old, which are the common patients in our unit, can differentiate or can understand the differences between these stages. So I mainly rely on the defecation or evacuation phase. This is a dynamic image. I comment on the degree of squeezing by, or the patient elicit the required pressure by seeing the bulge in the anterior abdominal wall. This is at rest here on the left, and on the right hand side we can see it during defecation. We measure the anorectal angle. This is at rest by measuring the angle between two planes at the one at the posterior rectal wall, which touches the levator ani, and the other line passing through the mid-axis of the anal canal, and normally the anorectal angle widened during defecation. The other planes are the BC line, pubococcygeus line, and we measure the descent of the anorectal junction here below the BC line. It's normally the M line normally below 2 centimeters in adults. This case it is 8 years old. We can see here elongation of the M line denoting pelvic floor descent. Also the hiatal H line, this in green here, measuring the pelvic floor hiatus. It's measured at rest and see how much changed during defecation. It's normally equal 5 or less in adults. So to understand the age variability, we measure the hiatal PC ratio to have a number we can compare among age groups. It's normally about 50%. I will show you a case demonstration. This is the first case. All cases are done in our MR unit. This case, 8-year-old girl with chronic constipation. During the echography, we can see here the patient is unable to expel the rectal gel. due to non-relaxing anal canal. We can see here also the anorectal junction. The anorectal junction here, there is no descent of the anorectal junction or abnormal widening of the pelvic floor hiatus, only non-relaxing anal canal. Another case, 6-year-old boy complains of constipation. The patient also there is squeezing with no expulsion of the rectal content. These are the various stages of the cine images. At the beginning, as a rest, no descent of the anorectal junction. However, during defecation, there is descent of the anorectal junction here with non-widening of the external, non-relaxation of the anal sphincter here. And finally, the patient's the anal canal widened and part of the rectal gel is expelled. We can see here non-relaxing of the puborectalis meli exerting a bulge on the anorectal junction. Also, there is a pelvic floor descent of the anorectal junction, defined as descent of the anorectal junction greater than 3 centimeters below the BC line. Also, there is laxity of the levator ani demarcated by vertical orientation of the levator plate. Another case is 13-year-old boy with chronic constipation. At the start of defecation here, there is a partial expulsion of the rectal content, but with marked descent of the anorectal junction. Also, finally, there is these are the various stages here with descent of the anorectal junction, partial emptying of the rectal content. We can see here interception and urethral hypermotility. I will show the magnified view. We can see here in yellow there is urethral hypermotility, abnormal posterior and inferior rotation of the urethra. Also there is interception in green and non-relaxation of the external anal sphincter. Another case is a 15-year-old boy with bleeding rectum at the end of defecation. Colonoscopy reveals a rectal ulcer. In static images after rectal gel injection, we can see here thickening of the left lateral aspect of the rectum and anal canal. And this is during defecation here. Also, there is a partial expulsion of the rectal content with descent of the pelvic floor. Here is a static image, these shots of the cine images. We can see here the constellation of urethral hypermotility with interception and the rectal pelvic floor descent in the presence of inflammatory process and rectal ulceration makes the diagnosis of psoriatic rectal ulcer syndrome, which is a well-recognized diagnosis that describes a combination of rectal prolapse and functional pelvic floor abnormality. The name actually is misnomer since it's a single ulcer is present in only 20% of cases, and actually there is maybe multiple ulcers at present in 40%, and the remaining cases display other morphologies including polypoidal masses and no ulcers at all. The last case is an 18-year-old patient with anorectal anomaly. It was a rectoperineal fistula, underwent anoplasty at birth. However, he complains of constipation and soiling. This is the static images showing sagittal T2 weighted image. We can see here buckling of the muscles behind the rectum, along as the anal canal behind the anal canal, along with marked fibrosis here. And the axial sections, we can see the anal canal is anterior to the transverse perineal muscle, along with post-ulcer fibrosis. This is the dynamic image. We can see here the patient is partially evacuating the rectal content with descent of the anorectal junction. This is a shot of the cine images. We can see here descent of the anorectal junction and pelvic floor descent. Actually, this is a very nice demonstration of the previous hypothesis we hypothesized on 2014. This is a case of anterior ectopic anus. This is a case of anterior ectopic anus in yellow, and the arrows, white arrows, demonstrate the direction of action of the the sphincteric muscles. When it contracts its normal scenarios, it would shorten and pass along the course of the anal canal. However, in case of anterior ectopic anus or anterior misplaced anus, it works against the axis of the anal canal, leading to its obstruction, as happened in this case. This is a normal anal canal during normal situation. The direction of force of the muscles is along the anal canal. However, in cases of anterior anal displacement, it works against the direction of the anal canal, which causes obstructed defecation. I will talk about one more thing. It's a dyskinetic puborectalis here. It's a normal contraction of the puborectalis causing anorectal angle. This is from the literature of an adult patient, causing narrowing despite obvious signs of attempt of defecation and in conjunction with delayed evacuation. This is dyskinetic puborectalis. To summarize, obstructed defecation, we can see rectocele, descending perineum syndrome or pelvic floor descent, interception and rectal prolapse, spastic anal sphincter, as we can see, non-relaxing anal sphincter, or dyskinetic puborectalis, or solitary pelvic ulcer, rectal ulcer syndrome. These are my references. Takeaway message: MRI is the ideal imaging modality for evaluation of pelvic floor dysfunction in children. MRI identifies pelvic floor anatomy and structural abnormalities at rest. Also, dynamic CINI MRI demonstrates pelvic floor laxity during defecation and functional abnormalities. Thank you very much.
Thank you, Dr. Shaima. Any questions? Any comments? انتوا بتخافوا من الام ار اي طبعا عشان ما حدش فاهم حاجه غير الدكتور عمرو والدكتوره شيماء، بس انا بس هنا عايز اوضح كذا حاجه. هو الحقيقه the entity of the puborectalis dyskinesia دي is very important if you are talking about the obstructed defecations and if you are going to do Botox injection for these patients, because in that situations we have to inject the Botox not only in the perianal area, but as well in the puborectalis itself. And actually, as I mentioned before, that the presence of what's called puborectalis reflex is an important continence reflex that we should consider in many of the cases and anomalies of obstructed defecations. طبعا الدكتوره شيماء حرقت لي حكايه السوليتري ريكتال ألسر از ميس نومر، بس ما فيش مشكله يعني ايه. ف very important is to the function of the puborectalis is that this synergia is not only about the function of the external or internal sphincters, anal sphincters. This is very important. And an important thing actually that is a query rather than a comment. Because of the descending perineal syndrome. In the cases of anorectal anomalies and in the theory of constipations by anterior ectopic anus, did you find any abnormal descent of the perineum in these cases?
In case of anterior anal displacement, yes, as in this case, we can, at rest there is no descent, but during defecation the patient shows descent of the pelvic floor.
تمام. هو the problem is one of the non-medical and procedural treatment for the perineal descent syndrome, which occurs in adults and as well in children, is to elevate the area behind the anus. That means to accentuate the anorectal angles that you are describing as the cause for constipations in these patients. Even there is a different types of commodes that's having posterior segments that elevate the perineum. So it can help patients with perineal descent syndromes to have a more normal type of defecation.
I always ask about if the constipation is a driving force for rectal floor prolapse, yes, or it is a secondary to the pelvic floor prolapse. Yeah. I think in case of anterior ectopic anus here, in this case, we should treat the primary cause, which is anterior anal displacement, to follow up if the patient will respond or to the clinical situation will improve. I think it will respond after corrective surgery.
Okay, thank you very much.
Thank you very much.
Yes, فضل. هو طبعا ليه زميلنا العزيز لان هو عامل دكتوراه بتاعته على الانوريكتال مانومتر. هو خد بالك يا مصطفى هو عايز ياخد منك القصه دي. انا بس ايه بقول لكم عشان عارف شهاب وهو يعني اتكلمنا مع بعض كتير، فهو ده why he is interested in this subject يعني.
تمام. انا بسال حضرتك يا دكتور اسامه بالنسبه طبعا هو الموضوع عامل زي البيضه والفرخه، انه اقرب يعني. فبالنسبه للاوبستراكتيفيكيشن انا بتكلم على الام ار اي ديفيكوجرافي ان هي مهمه جدا في الاستراكشرال كوزز بتاع الفانكشن كونستيبيشن اللي هو الريكتوسيل والبرينيال ديسنت والانترسبشن زي ما حضرتك اتكلمتي. لكن في معظم الحالات تلاقي ان الكوز الاساسي بتاعها هو الاوبستراكتيفيكيشن اللي هو الديسينرجيا او الاسبازم الموجود او الكلام ده كله. فعشان كده بس انا حبيت بس اتكلم عن نقطتين يعني حضرتك يعني ممكن تكوني شفتيهم اكتر مننا طبعا. ان طبعا البرينيال ديسنت تايب 1 او المايلد برينيال ديسنت اللي بيكون نورمال في معظم العيانين عندنا ده ما نجريش ان احنا نعمل عمليات عشانه او كده. وكذلك الريكتوسيل لان معظم الحالات بتاع الريكتوسيل بتبقى مايلد ديجري وبتبقى اقل من 2 سم، وتلاقي الام لاين اقل من 2 سم، وكذلك البرينيال هيتس اوبننج تلاقيها اقل من 5 سم او اقل من 6 سم. وبالتالي العيان ده لو انت حسستينه الاوبستراكتيفيكيشن او الديسينرجيا هتلاقي الريكتوسيل اتحسن او او ما زادش او ما عملش مشكله للبيشنت. لان احنا لو عملنا ريكتوبكسي او عملنا اسسمنت للريكتوسيل عملنا اوبريشن ليه او كده في الوضع ده ما اعتقدش ان هو يبقى مفيد للعيان شويه. فتراي حضرتك كيف؟
لا فعلا يو شود تريت ذا برايمري كوز يعني. بس هي الفكره هي كونستيبيشن مين الاول يعني، هو مين اللي جه الاول؟ هل هو الكرونيك كونستيبيشن ده I always asking about this point. Is a patient chronically constipated so leading to weakness of the pelvic floor muscles leading to pelvic floor prolapse, or the patient has congenitally weak pelvic floor prolapse that lead to chronic constipation?
Sometimes the perineal descent is the cause of the constipation and the interception of these things. And in some cases, you need to correct them by surgery.
هو في normal
the perineal descent syndrome, not in children but in adults للأسف. فإحنا في الchildren عندنا group already they are born with a perineal descent. These are the anorectal malformation patients because of the congenital weakness and the maldevelopments of their pelvic floor. So many of these cases have a perineal descent syndrome in a sense.
هو في ريسيرش موجود ان البي سي ال لاين المفروض لما يكون موجود في انتيريور وميدل وستيرو كومبارتمنت ان بيبقى فيه نورمال ديسنت، ان انت ممكن تعمل اكستراكت ل1 سنتيمتر من الانتيريور والميدل وتعمل اكستراكت ل 3 سنتيمتر من الميدل، يعني لحد اب تو 3 سنتيمتر من الديسنت ده اوريدي نورمال. بعد كده تبدا تشخصه اذا كان مايلد او مودريت او سيفير.
Thank you very much. Any more questions? Then somebody will introduce me back.
Thank you, Dr. Shayma. Our next speaker, our dear professor, Dr. Osama Nagar, he will give us some insights about the descending perineal syndrome and solitary rectal ulcer.
السلام عليكم. طبعا انا عارف بقى ان حضراتكم يعني زهقتوا من الكلام. الكونستيبيشن ده موضوع صعب جدا وفي الاخر خالص يعني مش عارف انتوا وصلنا الى a conclusion or a consensus about how to deal with cases of constipation or not. And I'm sure that in this session we will not be able to do this. In fact, I have been asked by my colleague Dr. Basuni to talk about solitary rectal ulcer syndrome. الحقيقة solitary, why we are talking in a setting of functional constipation about the solitary rectal ulcer syndrome. We have to know that this disease is very rare even in the adult population, and it is more rare in the children's. And most of these cases actually are diagnosed late in childhood. I mean, they are not diagnosed very early. The youngest in the literature diagnosed with solitary rectal ulcer syndrome was 1.5 years. But the usual median age for diagnosing these cases is about 7 to 8 years. So we are not facing in the very young children large numbers of cases of solitary rectal ulcer syndrome, and this may be because we are misdiagnosing them or we miss these cases in the very young patients. So maybe my lectures is the take-home message is that we have to suspect the presence of these conditions because it has consequences for the patients as well as his treatments and as well as the differential diagnosis from a more severe and intractable diseases. The solitary rectal ulcer syndrome is a chronic disorder characterized by mucosal ulceration. In fact, not all, as Professor Shayma said, not all cases of the solitary rectal ulcer syndrome are solitary, they may be multiple, and they may present without ulceration, they may present with polypoidal mass rather than the presence of ulcers. They are multiple. Usually they are found in the anterior wall of the rectum at the anorectal junctions, but sometimes you can find them at the sigmoid colon. So actually, the solitary rectal ulcer syndrome is a misnomer, and nowadays, if you would like to encompass the whole truth about the solitary rectal ulcer syndrome, you have to consider what's called mucosal prolapse syndrome. The mucosal prolapse syndrome will encompass this type of lesions, solitary rectal ulcer syndrome, what's called some polyps, some types of polyps, like what we call the cloacogenic polyps that's found at the anal canal. This is part of these syndromes. And rectal prolapse, either internal rectal prolapse or patients presenting with external manifestation of the prolapse. Sometimes hemorrhoids is considered as a mucosal or a part of the spectrum of mucosal prolapse syndrome. What's occurring in this condition is there is a hyperactivity of the pupil. There are theories, in fact, why solitary rectal ulcer syndrome occurs in these various types of morphological presentations and why in this area it is not very clear. But there are proposed theories, and the theory that is more prevailing in this situation is obstructed defecation problems leads to pushing of the rectal mucosa, the anterior wall of the rectums, inside hyperactive puborectalis muscles. This will lead to ischemia. Ischemia can lead to ulceration, polypoid or polyp formations, and leads to the sequelae of the presentation of the solitary rectal ulcer. In fact, if we look at the solitary rectal ulcers, it should occur in a setting of constipation. So the patient is constipated, but as you had heard today in the morning, that in any patients who had constipation, you have to look for alarming signs. In fact, the alarming sign in these patients with solitary rectal ulcer with constipation is bleeding, hematochezia, and as well as prolonged straining and incomplete feeling of evacuation or defecations. If you have a constipated patient with these alarming or red flag signs, you have to think about the presence of the mucosal prolapse syndrome. Here I would like you to mention for you two reflexes that we are missing in the continence mechanisms. The first is what's called the puborectalis continence mechanism and the external anal sphincter continence reflex. That means, although as you know that the external anal sphincter is a skeletal muscle, puborectalis is a skeletal muscle. Supposedly, they should not respond in a reflex way. But what is happening in that these two groups of muscles, that they behave reflexly in a way like the smooth muscles. Even there are some comparisons about the way that the puborectalis in a reflex actions work or behave, comparing it with the skeletal muscles contraction or the voluntary contraction that can we use when we want to do delay or postpone defecation. And they found that there is a big difference. So these reflexes are, these two skeletal muscles can respond in a reflex way, and these can have an impact on the way of understanding and as well as the way of managing of these cases. This paper, as you see, the title of it is the rectal prolapse, rectal inception, rectoceles, and solitary rectal ulcer syndrome. All these pathologies are now found or put under the umbrella of the mucosal prolapse syndrome. as you know, how does these patients present? Usually they present late in the childhood with rectal bleeding, mucosal discharge, tenesmus, straining dural bowel movements, perianal pain, constipation, and sometimes they are presenting with diarrhea, and this is very important. So although the solitary rectal ulcer syndrome occurs in the settings of constipations, but you should understand if the patient had these ways of presentations, and even if they have diarrhea rather than constipation, you have still to suspect the presence of the solitary rectal ulcer syndrome or mucosal prolapse in these patients. As well as some of these cases can present with stricture formation. And hence, the differential diagnosis of these conditions, the mucosal prolapse syndrome, is very important to differentiate them between actually two forms of diseases that their treatment is too much different from each other. The first is the inflammatory bowel disease, which can be presented with all these presentations. And the second one is malignancy, because as I said, the solitary rectal ulcer syndrome can present with a polypoidal mass. Or even the ulcers, as you know, the ulcers can be of a malignant origin rather than benign lesions. So differentiating these ulcerations or polypoidal mass that is accompanying a benign condition like the mucosal prolapse with inflammatory bowel disease, which is a very chronic and very debilitating disease that needs a very long period of treatment, as well as the malignancy and its sequelae that may be disastrous and dismal for the patients. So a differential diagnosis of these conditions, benign condition, from these more aggressive condition is an essential essential aim of our diagnosing these cases. As we said that the diagnosis here in this condition depends on the clinical evaluation, the presentation that we had seen, and endoscopy. So early endoscopy in patients with constipations with the flag signs or the red alarming flag signs that we we mentioned them before, the tenesmus, the incomplete evacuation, and the bleeding, necessitates that we have to initiate or institute an endoscopic examinations for these patients. In fact, the endoscopic examinations and biopsy from the lesion that is found and the mucosa and the normal mucosa beside the ulcers or the polyps is very essential, because by doing this there is a specific histological characteristics that can point to the diagnosis of the solitary rectal ulcer syndrome, and as well the intervening mucosa will not be affected like what's occurring in the inflammatory bowel disease, because as you know, in the inflammatory bowel disease it's a pan-mucosal or even sometimes transcolic disease of the colon or the intestines. So the mucosa that's intervening between the apparent lesions that we can see is not normal. Actually, even it's very important to know that the inflammatory reactions or inflammatory infiltrates in these histopathological specimens is very minimal in the case of the benign solitary rectal ulcer syndrome, and this is different from the patients with inflammatory bowel disease, and as well, of course, the dysplasia and the malignant transformations that we can, or the malignant or atabia, or the dysplastic cells that we can see in the malignant ulcers are not present in these cases. What are the most important? This is, for example, an example of an endoscopic appearance of a single ulcer with, as you see, there is denuded epitheliums and there is whitish base. The base of the ulcer is covered with whitish material. Here is more than one ulcer, so it's not necessary to be one ulcer. And here is another form of the solitary rectal ulcer where the morphological type here is a polypoidal mass rather than ulcer. No ulcer at all, but it's just a polypoidal mass. Here is the histopathological findings. Actually, this is a hand drawing or a drawing for the pathology. It's not a real pathology. The main important features is the lamina propria, which is this brown area, is infiltrated by muscle, and the muscles are arborizing in a vertical directions in between the crypts of the rectal mucosa. This is a very pathognomonic features in cases of solitary rectal ulcer syndrome, and we have to look at it when we are looking at the pathology of these cases. As we said, because there is problems with the defecation in these patients, and that's why these patients have tenesmus, and these patients have incomplete feeling of finishing their defecation. So the defecography, which Dr. Shaimaa had presented for us, the MRI defecography. But there is a conventional defecography where, as you see here, there is a puborectalis overactivity on the left side that making accentuation of these angles, and as well as you see here, there is a rectocele that is present in the same patients. So presence of rectocele, obstructed defecations, and here, I hope that these pictures is clear that there is a sort of internal prolapse. So internal prolapse, overactivity of the puborectalis, rectoceles, all these findings are found in these patients, and in fact, it is factors that explain the problem that is there, and as well, it contributes to the persistence of this problem and the difficulty and the complexity of managing these cases. Ultrasound can be of value because actually on the left side there is an increase in the thickening of the internal sphincter, and there is a decrease between, here is the external sphincter on the right side, and the ratio between the internal sphincter and the external sphincter thickness is disturbed in these cases of solitary rectal ulcer. So what are the management goals of these problems? First, we have to relieve the symptoms. Patient is having difficulties with defecation, and this affects his quality of life. So we need to relieve symptoms, improve quality of life, and if we have an ulcer, we have to promote healing of this ulcer. And we have to understand a very important problem in these patients, that these conditions is liable for recurrence. It's very difficult to treat, and it is the problem in that recurrence rate is very high in these patients. So it is not just when we had a good response for the patients by healing of his ulcers that everything is okay. We have to continue the treatment of disease patients, especially in behavioral changes, adoption of healthy lifestyles. All this is very important to prevent recurrence. What are the management options in these cases? Conservative managements, behavioral problems, behavioral interventions like regulatory routine and voice training, dietary, pharmacologicals using stool bulk agent and stool softeners. Biofeedback is very important to retrain the pelvic floor, and Botox injections, but Botox injections here, as we said, may be in two sides. The first is the external sphincters and the internal anal sphincters, the outlets, and the other one is the puborectalis. This is our old type of toilets, and this is a more healthy one like the European one that we are using. So actually, there are studies that had shown that all the problems of the obstructive defecations is less in the rural areas than the urban areas. So acquiring a modern lifestyles using European commode type and toilet types is not a healthy one. Squatting position, this is called squat toilet. So the squat toilet is a better way of doing defecations, but I think that we cannot do it now. We had been modernized to the extent that we cannot go back, and if I ask any of you to do in his house a bathroom like this, it will be very difficult to convince. What are the medical therapy? And actually, the medical therapy here is topical treatments using of enemas. The sucralfate enemas. The sucralfate is a drug that is used for peptic ulcer healing. So using it locally is important. أو the الميزالامين enemas اللي هي sulfasalazines. والcorticosteroid enemas can be used locally to promote healings. And as well, we give oral laxatives and to treat the constipations that is there. What are the surgical treatments? If there are a rule for surgery in these cases, yes. The indication is failure of conservative and medical treatment. There are a lot of types of surgery that can be done in these conditions. Either mucosal resections, doing rectopexy, Botox injection, and sometimes local resection. One of the newly administered modalities of treatments that is very helpful in control bleeding as a sign of this disease is the application of the argon plasma to help control the hemorrhagic ulcers in these cases. As we said, outcome is possibly good, but recurrence is very high. As we said, most children improve with conservative treatment. Long-term adherence to treatment is crucial. Long-term for monitoring for relapse is very important. This is, for me, is a very interesting slide. I hope that you can see it. This is about a French physician's survey about the treatment of the solitary rectal ulcer. And in fact, this is not in the children's, it is in adults. And it shows clearly here what are the therapeutic strategies and what are their actual rule in managing these cases. You see that the recommended strategy as the first line treatment, laxatives and biofeedback mechanism or biofeedback. If you need surgery and you find or diagnose the presence of rectal prolapse, rectopexy is an important one. There are some modalities of treatment, but it's not well evaluated in the literatures, like the sacral neural modulations, the transcutaneous electrical nerve stimulation, hyperbaric oxygen as a mean for inducing healings, and the Botox or botulinum injections. As we said, argon plasma beam is very important mode of managing this case, especially to control hemorrhage or bleeding. The psychological support, although not so well evaluated or validated, but is considered as a very important adjunct for managing this type of what we call functional problems. But here we have to understand, because I hear a word today that when we say functional problem, so that means it's a simple one. It's not. And as you see here, a functional problem that led to a too much morphological and anatomical derangements that needs a more aggressive type of treatment. From the topical medications that we mentioned, in fact, the evidence, as I said, always I'm saying that we can't say a lot of talks, and if we are not putting these talks in the context of what are the data that supporting these talks, so we are just doing talks. So corticosteroids, enemas, sucralfate is having a good response in these patients. Corticosteroids, according to the French experience, is not of any value. Although, as you know, that the corticosteroids is one of the means to manage cases of inflammatory bowel disease. You may use corticosteroids as a topical treatment to control patients with inflammatory bowel disease. A more drastic and far-lifted operations or interventions is stoma. Sometimes no response to all these treatments, even if you did surgery for these patients. And so some are doing stomas. And stomas actually is not recommended and it's not well validated. So solitary rectal ulcer syndrome is rare but important entity to detect early. Multidisciplinary teamwork treatment is essential. Conservative treatment is the first line treatment. Surgery is indicated in refractory cases. And as well, ongoing education is helpful to prevent recurrence. This is the summary of the topic of the solitary rectal ulcer. Thank you very much.
شكرا دكتور أسامة. استمتعنا جدا. Very illustrative talk. Thanks دكتور أسامة.